All right, hello everybody. Today I'm with Dr. Bob Krueger from the University of Minnesota. He's a professor in the Clinical Science and Psychopathology Research Program. Thanks for coming on today, Bob.
It's my pleasure. Thanks for having me.
Yeah. Um, so I just wanted to start with getting to know a little bit about yourself, about your research, how you got to where you are, how your research interests developed, things like that.
Yeah, so I I was trained as a clinical psychologist at the University of Wisconsin, which is also where I did my undergraduate work. So I stuck around Wisconsin for grad school. And I got interested in problems of comorbidity and kind of the nature of psychopathology initially from clinical experiences, where it became clear that traditional DSM style categorical ways of approaching case conceptualization, right? So basically what would be the right categorical label for a particular patient, and how would you use traditional psychiatric, rubrics to inform the way you might approach intervention? It became clear that didn't work well because many, if not most, patients just didn't fit neatly into those categories. And so then I started to do research to try to figure out, why that might be the case, and did the kind of stuff that, you're aware of that led you to invite me to chat with you today about, how you might develop more empirically based, evidence-based ways of conceptualizing the nature of psychopathology.
Yeah, and so yeah, today I'm hoping to talk a bit about the hierarchical taxonomy of psychopathology, or the HiTOP. So I just wanted to start with a little bit of the history of nosology when it comes to psychopathology. Um, Obviously, you have like the Greeks looking at things like the humors and all of that, but more looking into the 19th and 20th century. Um, how did we get to where we are today in terms of classifying psychopathology and maybe taking a more objective lens at it?
Yeah. So can you say that question again?
I just wanted to kind of set the stage for how we got to where we are today in terms of the history of nosology or of classifying psychopathology. So, obviously in the 20th century, like we had the DSM, I don't know, it started with the DSM-3, but like what do you know of what happened before that, of how people started to look at classifying psychopathology?
Yeah. So it's a question of kind of like how far back do you want to go?
Sure. Let's just start with the DSM.
Yeah. So the DSM, has a history that sort of begins in the mid 20th century. I guess one way of talking about it is to point out that psychiatric classification was, not the most exciting area, right, of psychiatric scholarship and thinking.
Sure.
Um, right. So in those earlier eras, right, because there's of course a history that antedates even the mid 20th century. But if we think about kind of when DSM-1 was published, as I recall, it was in the 1950s, right? The basic purpose of that kind of classification was to, count the number of cases at um, specialized facilities like state mental hospitals. Um, and for the purposes of, what was kind of, the intellectual activity within psychiatry as a discipline, it was much more psychoanalytic, especially in the United States. So there was much more of an emphasis on, what would you call it, underlying dynamics, right? And unconscious conflicts and sort of concepts like that that trace back to Freud, and to psychoanalytic thinking. Those were the things that people were interested in. And classification, was seen as sort of tangential to understanding those kinds of dynamics. Um, so so what sort of happens next, right, is a shift toward what has often been called a neo-Krapelinian approach, right? So Kraepelin was a was a famous German psychiatrist who actually was a contemporary of Freud. So that gets kind of interesting. Although Kraepelin had a very different approach that focused more on taking a careful history, right, in the interview. So trying to understand the patient's particular and specific history of symptoms and kind of focused on differential diagnosis, right? So find the right categorical label based on history as well as, sort of current presentation versus the sort of Freudian approach, which was more about underlying, psychological dynamics that are often conceptualized as unconscious. So those approaches were running in parallel for much of the 20th century, in the United States, with the psychoanalytic approach having kind of the dominant role until you reach kind of the 1970s when a group of psychiatrists who are often called the neo-Kraepelinians, right, referring to Kraepelin's historical influence in Kraepelin's textbook. So they became interested in the idea that we should not, discard nosology, right? That there were major mental disorders, particularly mood and psychotic disorders, that could be well delineated based on Kraepelin's traditional approach. So that sort of shifted, right? And along with that came an increasing emphasis on biology, and the idea that you could understand these things better, not with reference to underlying unconscious dynamics, but with reference to using contemporary biological technologies, right? And as those technologies became more compelling, particularly with the rise of, things like the ability to narrow image, humans who are intact, right? So as that kind of came together, right, that was kind of the conjunction that led to contemporary biological psychiatry, as you might call it, right? So I don't know if that's enough of the history to sort of respond to your question, but that's kind of how that went, right, from the mid 20th century to where we are today, with really the biological psychiatry paradigm being ascendant, particularly in the United States, right? So the idea that there are these, sort of quote unquote legitimate categories, and they ultimately can be delineated with reference to underlying biological processes and right, and the whole idea that mental illness is the result of a quote unquote broken brain, right? This kind of approach, which I think still has a lot of ascendancy, although there's, appreciation for the limitations of the categories, that I think is often it gets more attention, right? Has received short shrift at various points in that history, but gets more attention now. So I don't know. Does that answer your question?
Yeah, yeah. Just kind of setting the stage. So, yeah. So obviously, it sounds like what you're kind of saying before is that with like a categorical conceptualization of psychopathology, like in the DSM, you said in your like kind of case conceptualizations, there were some shortcomings, especially with problems of comorbidity and overlap of symptoms. And in just about every HiTOP paper, right at the beginning, it kind of goes over what those issues are. So, yeah, can you say more about how what led to the conception of HiTOP? Obviously it was sounds like some degree of noticing some problems with categorical conceptualizations of psychopathology. And then how did you get to know the people that started the HiTOP with?
Yeah. Well, so right, you're right. High top emerged in that kind of intellectual context, right? With the understanding that categories had various shortcomings, right? And so what were those shortcomings, right? They Patients tend not to fit into one and only one specific category, right? So you can think about that as the comorbidity problem, right? Most patients will meet criteria for multiple disorders, at the same time. And, a related problem is heterogeneity. So you find people who are supposed to be members of what is supposed to be a homogeneous singular category. And you find that there's a lot of diversity of presentation and history, and prognosis, right? Which really is kind of the goal, if you think about it, right, of diagnosis, right? Many have argued that prognosis is kind of the point, like figure out how to predict what's going to happen so you can intervene successfully. Right, so there's all this heterogeneity within the categories as well as comorbidity. And HiTOP emerged in that kind of context with the realization that the categories had these limitations. So how could you address them? And the paradigm that HiTOP adopts says, we'll rely on data, right? Because the categories emerge from clinical observation primarily, right? Along with some research that's constrained by the idea that the categories are legitimate. Um, right? It's not like there's no research, but the research is constrained by the assumption that the categories are the right way to conceptualize the phenotypes, if you will, like the presentations.
Yeah.
So it's not like well, in fact, there's quite a bit of research that uses the categorical conceptualization, but not so much research that attempts to um, develop a more compelling and evidence-based approach. So
Oh,
that's where HiTOP's coming from, right? Trying to use data to
yeah.
figure out the nature of psychopathology.
Yeah. And so, it was from what it sounds like, it was you, David Watson, and uh, is it Roman Kotov?
Correct, yes.
Yeah, and so you three kind of started it. How did you guys get together? What kind of angles, different angles were you guys looking at the problem? Definitely seems like there's a lot of interest in um, integrating personality when looking into psychopathology. Yeah, how did you guys get together?
Well, we had known each other for a long time, and had worked together at various points. So Roman got his PhD at Iowa when David was on the faculty there. Um, so, we had known each other for a long time, and we were doing, similar kinds of research in that vein of like, okay, how can we, improve the approach that's undertaken in the DSM, basically, and decided that the best way to do that was to work together. Because we had each been doing stuff sort of separately. Um, and decided we would join forces, basically.
Sure. Um, and I'll put some visuals on the screen for people who are unaware of what the model is, but there's plenty of reading material. But basically, and correct me if I'm wrong, is that you can, the high top is a kind of like a pyramid with different levels, the spectra, super spectra, subfactors, and then like you get into um, the syndromes and the symptoms and stuff like that. And so it sounds like obviously there was a lot of statistics going on into making these categories. And I know uh, one of your most cited papers is on like discovering kind of three. Was it like, internalizing, externalizing? I don't remember the third one, but three of those kind of factors that are all correlated with whatever sort of mental disorders. Um, so can you talk a little bit about, yeah, the sort of statistical modeling that went into creating HiTOP?
Sure. So without getting too technical, right? The idea is
Yeah,
that the mental disorders are indicators of underlying dimensional spectrum concepts, right? So it's not like there are, literally hundreds of discrete categories as the DSM sort of proposes, but rather those presentations are organized into these more dimensional, kind of spectrums, right, of interrelated sort of conditions. And as you alluded to, you can kind of see a number of different potential organizational schemes that are compatible with the data at different levels of resolution, right? So that's the whole hierarchy idea, right? You can think about broader spectrums as well as more narrow and specific spectrums, all the way down to very specific symptom profiles. Um, but because those things are correlated with each other in specific patterns, you end up with this kind of hierarchical organizational structure. And a high level of that structure, as you suggested, right, there are kind of these large groupings. And those, groupings could be thought of as more internalizing disorders, right? So like anxiety and mood disorders, externalizing disorders where people are, acting out, and psychotic disorders where, reality testing is a big part of the issue. Does that make sense?
Yeah. Yeah. And I always kind of run into this question, and when it comes to like the five-factor personality traits and also these spectra is like, what exactly are these measuring? Because with symptoms, obviously you can look at real behaviors and things like that. And with these ones, it's, I guess part of them are based off of behaviors, but they're also, statistical concepts, and you can also, work is you can find like neurobiological underpinnings. So there's all these different kind of layers of how they're being measured. How can you best understand what these, spectra are, or, any of these traits or things like that?
Um, yeah, I'm not. Can you say the question again? I just want to make sure I understand it and can
Yeah.
give it.
So, um, when we're talking about like these statistically created concepts, like, you know, um, let's say internalizing, for someone to be high on like the internalizing spectra, or however you want to say it, I guess what I'm asking is like, how do you understand what they are, in terms of, um, like what I was saying before is, you can measure, you're measuring them somewhat. I mean, correct me if I'm wrong, like, through behaviors, like some symptoms and things like that. But also, I know work is being put into measure their like neural correlates. So I guess it's kind of a nebulous question of asking what are these statistically derived concepts measuring, or what are they?
Yeah. Okay. Well, so they're literally like things you would see in the clinic because
Okay.
that's really like the subject matter of, well, I mean, psychiatry and the other, sort of allied mental health disciplines, right? Like, so people don't complain of, uh, you know, well, how do I want to put this? That's why people present, right, for services because they have certain issues, right? And it could be that you know, their mood is low, right, or their mood is highly variable, right? So they have mood disturbances or just problems with emotion regulation, right? That's a common reason people present. Could be that they're court ordered because they're having problems with substances, right? That's another common reason. Could be that others people are concerned about their behavior, right? Could be that, the police bring them in because they are behaving in an erratic and disorganized way, right? Things like that, right? So that's where the public health significance is sitting. It's what people do and how they feel and how they, you know, think really, right? Like, so it's that kind of basic conjunction of people's um, subjective sense of how they're feeling and thinking and objective, behavior that other people observe that's a problem that brings them in. And then you can think about HiTOP as a way of conceptualizing in an empirical manner those patterns of behavior, thoughts, and feelings that bring people in for services. Does that make sense? And the way you
Yeah.
find out about that stuff is you have to ask people, right? You can ask the person themselves, you can ask people who know them well, right? You can get objective records, right? Like you figured it out based on what it is and what it is. That is to say, the public health thing that brings people in to seek services is well, behavior, affect and cognition essentially. So then, like as a next step in that kind of thought process, you can try to figure out, well, why is that happening, right? Like, why are some people prone to mood dysregulation? Other people are very stable and have an even keel, right? And it's at that level that you can ask things about, like, can we use contemporary biological technologies to try to figure out the correlates of these experiences? But no, you wouldn't want to reduce the phenomenon per se to something like a pattern that you could see, in a scan. Well, first of all, you can't based on the contemporary evidence, right? The links are too loose between stuff that you could observe in something like, an imaging paradigm and the things that people complain about or how they behave. Like the connection is too loose based on the evidence. Um, so you can't let's put it this way, you can't diagnose mental disorder based on a blood test, for example. Nor do I think you ever could, because conceptually that's not what it is.
Mm.
Like imagine that you had a blood test that was pretty sensitive and specific for, I don't know, recent depressive, experiences. Just imagine that that was developed, right? So you could run labs as you do when you go to the doctor and get test results. But imagine a person is clearly depressed based on their mood, their thinking, and their behavior, right? That they come in with. Like, they can't get out of bed, can't go to work, right? Have all the classic signs of serious vegetative, as you might call it, right? Like depressive symptoms. And the blood test comes back negative. Like, what are you going to tell them? Oh, the blood test was negative, so I can't help you, right? It doesn't make conceptual sense.
Yeah.
So it's always going to be based on what people are experiencing and how they're behaving. And then, yeah, that's not to say it's not important to understand, because this will be very scientifically useful and could provide important pathways into intervention. Like it's important to understand why there are those individual differences, like why people present in different ways and why people have different risk for mental illness throughout their lives. Right? That's a critically important step, but it has to be tethered to where the public health significance is sitting, which is in people's patterns of behavior. Does that help explain at least my perspective on the whole thing?
Yeah, and I guess one thing I've been trying to wrap my head around is that specifically looking at the spectra of the high top, there are you know correlations between and I guess I don't know the statistics well enough to say whether it's correlations or some other concept, but between the five factor models, for example, like internalizing and neuroticism, and then also the alternative model of personality disorders. And to me, I'm trying to understand why there is this kind of correlation between them, and if it's if we don't understand it well enough, or if there's like something that these are all revolving around for each five personality trait and spectra. And I know all of them aren't like uh established, especially when it comes to openness, but um do you see what I'm trying to say? Or
Yeah, you're looking for a reason why we get these five basic factors in personality research.
um I
Is
guess
that what you're
so.
asking?
Yeah, or like why, is it a consequence of the way that we've modeled everything statistically? Um, or is it is there some, biological underpinning of or evolutionary result of these personality traits? I guess it's kind of asking for questions of causality and questions of, the origins of where these things come from.
Yeah, so why does it why is it structured the way it's structured? Like why do human individual differences in personality tendencies coalesce along in those big five groups? Is that
Sure,
kind of the
yeah.
question?
Yeah, yeah.
Yeah, well, that's an important question. I can't claim that I have a definitive answer. Um, but I think in a lot of cases you can make a case kind of based on inferred evolutionary pressures and phylogeny, if you will, right? Like there are similar kinds of patterns that you see in infrahuman mammalian species, for example, right? Like you can see kind of these big dimensions if you study animals, for example. And it probably works that way because there are systems, right, that underlie those big five structures, particularly the sort of extroversion and neuroticism part, where you can make a reasonable case that that has to do with systems that are related to approach, right? So kind of what Gray called the behavioral activation system, right? So kind of like dealing with reward and approach and with how the organism has to, navigate the world in order to obtain important reinforcers like food and sex and so on, right? So
And
that,
that's more on the extroversion side
yeah,
is,
exactly, right? That's like,
yeah.
in humans, it's very social, right? Because we're such social creatures. So I think that's why you see that system manifest in extroverted behavior, outgoing, friendly, engaged with other people, right? Because that's very reinforcing for humans, generally speaking. And then the neuroticism part, which is, avoiding things that are dangerous, right? Or painful or hurtful. And of course, in humans, right, that gets really elaborated, right? Because, neuroticism is associated with a bunch of thinking about the future and envisioning potential disasters. Because humans are prediction making machines in a lot of ways, right? Like you're trying to figure out what's likely to happen next, or at least that's what your brain is trying to do. So, yeah, I mean, I think that's why you see those kinds of structures because they're linked to major systems having to do with regulation of the organism in intersection with the environment, where the basic way in which you have to approach the environment is look for reinforcers and avoid, painful things, right? So
Yeah.
you're seeing the signature of those systems and their basic parameters, right, in human individual differences in extroversion and neuroticism. And the other themes, right, probably have to do with other brain systems that you could potentially uncover, right, or articulate, right, having to do, in the case of conscientiousness, with organizing one's behavior with reference to future goals, right, as opposed to kind of like current issues. With agreeableness, right, having to do with how to navigate the social world in terms of getting along with others. And openness having to do with, are you going to be open and exploratory or are you going to like kind of close down? But the systems, right, like in a sort of neuroscience sense that are associated with those additional domains, I think are more poorly understood. Whereas I think I can make a case for what's some of the relevant, if you will, neurocircuitry, right, for things like extroversion and neuroticism. But that's my suspicion, right, that ultimately what you find is that these things are instantiated in major systems within, the human brain, right, that have to do with navigating these basic parameters of our lives and how to put this, right? Like basic parameters of how those systems function. And that's not to oversimplify it, right? It's not like there's a single scalar number, right? Like some value, right? That's sitting in your brain that's like, okay, this is your conscientiousness level. But rather that like a bunch of systems are coherent enough, right? In terms of how they function, because they're dealing with a broad class of concerns or stimuli, right? And kind of they're being sort of mediated, if you will, through those systems, right? Broad classes of stimuli. Um, that the parameters of those systems, which are going to be multiply determined, of course, are the underlying mechanics, right, of why there you see the big five personality traits.
Yeah. Um, so another question I want to ask is, with the big five, there's been research on the facets or aspects of the traits, so breaking them down into however many number of like subcomponents, which, as you were saying, you're not going to just identify one number for conscientiousness or something and use that as a predictor for whatever behaviors, but you can also break it down more. And obviously that still won't be sufficient to predict whatever behavior, but then you can look upwards the other way and look at meta traits of plasticity and stability. So is there any research into the using of yeah, the meta traits or the facets or the aspects and seeing correlations between those and the high top?
Right. So I guess now you're asking about how AMPD interfaces with HiTOP. Is that kind of the question?
I'm not too familiar with the AMPD. Are those uh are like plasticity and stability and all those other like sub facets and things also integrated into the AMPD?
Oh, right. So the AMPD, right, just to say a little bit about where I was going with that, right, is
Yeah.
the alternative model of personality disorders, right, that's in the DSM-5. And it's a a forward-thinking approach that relies on or sort of instantiates the concepts from personality psychology that we were just talking about, right? And so that's why my mind kind of went there
Okay.
because it's kind of this link between academic personality psychology and psychiatric classification, right? In relying on
Mm.
big five type structures to figure out the way to think about personality disorder in clinical settings. Yeah.
Yeah.
So anyway,
Yeah.
like that's why I was going there, but you don't need to go there. So I think what you were now asking about has to do with the personality psychology literature per se and concepts like stability and plasticity, right, which are kind of these meta traits, right, sitting above the big five. So yeah, like plasticity, right, has to do with extroversion and openness, and it's kind of about exploration of the world, right? And stability has to do with managing the rest of everything, right, which is relevant to the other domains.
Yeah.
So so yeah, there's evidence for those structures at a level above the big five, and that hierarchical approach is in some ways similar to the approach that's taken at HiTOP. So maybe that's what you were getting at.
Yeah, I guess I was just asking because I don't know if there's research showing that, you can take the five factor model and then also interface it with the high top model and find asking if there's any correlations between those two or um I'm just curious as to why, yeah, if the five factor models traits have associations, do also the upper, higher and lower level traits have associations too?
Yeah,
So, are there pathologies of stability and pathologies of plasticity that can be, then integrated into a, a nosology?
yeah, that's an intriguing way of putting it. The presentation, well, let's put it this: the traits that are associated with the stability domain are pretty similar to what in classical psychiatric nosology is called borderline personality disorder. So yeah, I
It-
think there are some parallels there, right? Because
Do you,
borderline involves not just neurotic style emotional dysregulation, but also dysregulation in terms of things like conceptualization of self and other, and planning for the future, and like impulsivity stuff is included in that category historically.
sorry, which trait did you say? Or which,
Also, the stability meta trait that you're referring to, it's kind
yeah,
of a mix of neuroticism, unconscientiousness, and disagreeableness, right? So you can think of it as instability, if you will. And that
yeah,
set of um, behaviors, right, like is similar to what's described as borderline PD in the psychiatric literature.
yeah. Interesting. I didn't know that. That's interesting. And because those, I recently read uh, the paper with, forgot who wrote it, but uh, looking at five factor model traits and psychopathology, and yeah, those three exact combinate the personality profile you were saying was like one of the main findings. Obviously, there was a lot to the paper. I don't know if you know what I'm talking about, but um, sorry. Okay, so were you gonna say anything else about that?
No, I think that's pretty much what I was
Okay,
thinking of.
yeah. Okay, so kind of covered the high top. The next thing I wanted to talk about was so in March of 2023, there was a paper put out with kind of some criticisms against the high top. And um, when I read it, there seemed to be some disagreements about kind of the role of statistics and kind of empirical and theoretical the role of those sorts of factors in creating models and kind of some like higher level disagreements in the philosophy of science and maybe psychology about how to include those things when making the high top. So the first question is, how did that paper kind of, or did that paper influence and affect how you guys construed the model or things like that.
Um, I think I know the paper you're talking about. It. Can you remind me, like,
It's the hateful.
yeah, okay,
Um,
yeah, I know what you're talking about.
yeah,
Yeah, so there was a whole exchange based on that. So there was that sort of target paper, and then we wrote a kind of response to it.
yeah.
I would point you to that response in terms of, how the points that were made by Hateful and colleagues were, you know, countered essentially by the high top perspective.
Okay. And were there any you know, changes that you guys made as a result of that, or were you able to like, yeah, counter all those things? I guess.
Yeah, and to be frank, I didn't see, nor did most people in high top, tremendous value to what was being stated in that paper, because I think it was mostly based on a kind of misreading of the relevant evidence and
Okay.
kind of misunderstandings about, a lot of important concepts. And so in our response, we clarified some of those points. So that's where I would refer you
Okay. Okay.
to the exchange itself. Now, of
Yeah.
course, like, constructive criticism is always really useful in science. And there are ways that you can talk about, limitations and shortcomings of approaches like high top. But, the way to handle that is to come up with something that addresses them empirically. Right. So, like, if you don't think things are dimensional, you can articulate a statistical model that conceptualizes the underlying structure of human variation as, discrete. So you can go ahead and do that, right? And you can fit that model to data and determine whether a discrete model or a continuous model is a better account of the relevant evidence. And that's how you do science, right?
Yeah.
But I think in the case of that particular exchange, a lot of what was being stated was just, based on a misreading or misunderstanding of the relevant evidence.
Okay. Um, yeah. Okay. So, obviously now it's been what, close to 10 years, or there's been some time since the first, like for the high top to develop, but what are kind of the next steps that the consortium is doing to, um, fully validate the model and also, implement it clinically and, what's the future vision kind of look like?
Yeah, well, there's a lot of activity within HiTOP. I would refer you and your listeners to the website. I don't know if you have the HiTOP website. I can put it in the chat.
Yeah. Yeah, no, I can put that there.
Yeah, I mean, there's a lot of stuff that's going on within the consortium. There's a society, right, being formed, like a scientific society that's connected with HiTOP that's coalescing. So people can become members of the society and attend the, yearly meetings that we have. Clinically, there's a whole sort of clinical work group that's connected with HiTOP that's pretty active in terms of doing workshops and other activities to kind of roll it out. There's a clinician network, right, that's formed of active clinicians who are interested in HiTOP and how to use it in the clinic, right? So that's where I would go for that kind of information. There's just a lot going on. It's hard to summarize rapidly.
Sure, sure. Yeah, and yeah, there's some I read some of what was being said about like the next step for like clinical use and right now it sounds like people who want to use the model clinically can kind of translate their um the high top codes to like DSM or other codes, for insurance purposes. But just like a practical question, like how do you even start to, get insurance or, other psychological associations to accept something, an alternative model of, yeah, psychopathology?
Yeah, well, so I'm not super worried about, I guess, insurance, right? Because
Yeah,
that's kind of it's an important practical thing. But I think, systems like the DSM are suited to that because the point is just to put something down on on an encounter form, right? On a, like when you see somebody for services, you just got to put something down so that there's a connection, and the third party payer, right, like the insurance, has a basis for saying that the legitimate clinical services were delivered.
Yeah.
Um, right. So what I'm saying is something like HiTOP is more scientific, right? And so it kind of comes
Okay.
into play based on actually being effective, right? And if you have a system that better maps what people are really like, then that would be a basis for case conceptualization. Now, ultimately, right, there's a kind of crosswalk between the kinds of codes that are sitting as billing codes, right? So technically speaking, the International Classification of Disease, which is published by the World Health Organization, is the basis for the billing codes throughout medicine. And
Yeah.
then
Yeah.
psychiatry and other mental health disciplines. So it's the ICD codes that you use when you see a patient.
Yeah.
Um, and there's an easy way to kind of crosswalk between HiTOP conceptualization and the extant, sort of ICD codes. But I think that might even be on the website.
Yeah.
I don't think you need to like change the way the insurance business works, right? Like the idea,
Sure.
right, is that if HiTOP reflects the actual evidence-based nature of psychopathology, then that would be the basis for continuing the scientific endeavor, right?
Yeah.
That you would predict things like, oh, understanding, neural systems will coalesce along HiTOP kinds of dimensions, and there's evidence for that, right? And like understanding the genomic risk, right? Like for psychopathology, that those patterns will also resemble those of or the phenotypic structure that HiTOP delineates, right, will provide guidance to what you'd want to study, right, at the genomic level. Right. So, like, as that all kind of comes together, it becomes inevitable that clinical practice will be informed by science, or should be.
Yeah. So I guess the reason I ask is, if there are serious flaws with the DSM and if people are using like, you can search up a PDF of the DSM and especially when it comes to, people who are struggling with psychopathology or just other, non-scientists, um, if they're looking for the, DSM or ICD or other things like that as the authority for how mental illness works, at what point, uh, I guess the main question is how might the high top change, yeah, a layperson's understanding of mental illness? If it's not just, oh, I have depression or PTSD, if it's actually these other, or is high top not in a state if it, too st statistical, empirical, or scientific for like public under understanding, I guess. Does that make sense?
Yeah, no, I think it does, right? So, like, you're talking about basically the interface between what scientists are pursuing and kind of how to communicate about that with the general public.
Yeah,
Yeah, I don't think it's too hard to explain how HiTOP works or why it's different from the DSM.
sure.
Um, I mean, I think the website attempts to do that in a way that's approachable for anybody who's interested in this, right?
Hmm.
And isn't too technical in terms of how it's set up, right? As you delve into the scientific literature, it gets a little more technical, but it's not, I don't think it's hard to explain, like, okay, there aren't really discrete mental disorders, there are these spectrums. But many people's experience of, psychopathology is like that, right? People get
Yeah.
frustrated because they, are looking for the correct categorical label for their experiences, and they get different labels from different providers over time because, their experiences change, right? These categories aren't indelible. And um, I guess what I'm saying is I don't think it's too hard to explain the idea, right? And I think
Yeah.
a lot of people's intuitions about this, not surprisingly, match the way it, quote unquote, works in nature, which is what HiTop's trying to articulate.
Yeah. That makes
So,
sense.
yeah.
Yeah. Well, yeah, if anything, it would um resonate with people more if it's really reflecting how, yeah, psychopathology works.
Hmm.
Um yeah, okay. So yeah, I was gonna ask about how high top has changed your understanding of psychopathology, which we seem to kind of covered. And I guess another question is, how does there's definitely people out there and movements in the past kind of challenging the notion of mental illness and saying that it's a social construction. So how does the empirical basis for high top kind of challenge those viewpoints?
So which viewpoints are we talking about? Let me just try
Uh,
to make sure I completely understand that.
yeah, like classifying certain, so maybe with antisocial personality disorder or any sort of you know labeling a behavior as maladaptive or pathological, and using that as a and saying that that's a socially constructed viewpoint and or a socially constructed phenomenon. Saying that we have an empirical basis for psychopathology, or rather than, let's say, in the past with the DSM of like, a group coming up with, okay, well, we think that these kind of categories exist, and rather than actually looking at as much data as you guys have. Does that make sense?
Yeah, I apologize, but I'm having trouble just tracking exactly
Sure.
what the question is that you
Yeah. Sorry,
want me to.
I'm jumping around a little bit. Well, maybe a better question is, are there still people who doubt the reality of mental illness? And yeah, that's the first question, I guess.
I mean, maybe. You mean like if you did like a general survey of the population and asked the question like, is mental illness a real thing or something like this?
Sure, but also I don't know, like past like anti-psychiatry movements. I could be just kind of misconstruing this, and I'm just trying to cover all the bases of whether or not this model um, adds more to the validity of psychopathology, if that makes sense.
Yeah. I don't know. It feels a little naive to say like people don't experience psychopathology. That's an easy one to kind of like counter.
Yeah, definitely.
Um,
Um, I'll get back to you on that if I can clarify that better.
sure.
Um, so okay, the last question I had on here was one thing I found interesting was that there were gender differences between like internalizing and externalizing. Um, and I don't know too much of the literature on like individual differences and or gender differences in that area. So I guess the question was just why might those differences exist?
Okay, so the question is why are there gender differences in the prevalence of mental illnesses?
Uh, yeah, and I guess where do they exist in the HiTOP model? Like in the different spectra or subfactors that you've found.
Yeah. Okay, yeah, I think I understand that question. So we and others have published evidence suggesting that it's at the spectrum level, right? So rather than there being observable gender differences in the prevalence of specific DSM style diagnoses, the evidence is more that the gender differences are kind of sitting at the spectrum level, right? So to make a long story short, there's evidence that persons who identify as female or thinking about sex as a biological variable, right? Because I don't want to give short shrift to the fluidity of gender experiences, right? But
Sure.
you
Yeah.
conceptualize it um, as a biological variable, like how NIH talks about it, right? As sex as a biological variable, or people who identify predominantly as female versus those who identify predominantly as male, um, there's evidence that those classifications correspond with risk for mental disorders in such a way as to map the spectrum structure rather than the structure of particular syndromes. Right. So, like, again, an easy way of saying that, right, is that there's enhanced risk for internalizing presentations in persons who identify as female versus male, and vice versa for externalizing presentations.
Okay. Um, okay. I think that's all I have for you. So thanks for coming on and trying to decipher what I was trying to ask. But
Oh, yeah, no, it's my pleasure.
yeah,
Thanks for your interest in our work. I appreciate that.
yeah, definitely. I'm and yeah, there as you said, there's a lot on the website and plenty of reading. But the main reason I wanted to make this was because if you go on YouTube, you can definitely find some things on HiTOP, but um, I didn't find a lot of long and there's some of your content too, although it didn't focus on HiTOP. So I figured I'd put myself out there and try and ask some questions and kind of create more awareness of that these things exist within psychology, since at least people that I know don't that this is all new to them. So
Yeah,
in
no,
the
thanks for taking the time to do it. I mean,
in the
that's much
younger,
appreciated. And as you
yeah,
suggested, right, like talking about these newer ideas in a way that's approachable is challenging, but an important endeavor to try to undertake. I would just point out that, Professor Miri Forbes, who's, been very active at High Top, and her group have posted some content, as I understand it, on YouTube to try to explain what High Top's about. And I would point to some of that stuff.
yeah.
Might also be
I'll
listeners.
yeah, I'll definitely link that and put that out there.
All right.
But yeah, thanks for coming on.
Yeah, no, my pleasure.
All
Great
right.
to talk with you today.
Yeah.
All right, take care.
Yeah. Bye bye.
Bye.